Hi everyone, welcome back. The topic for today's discussion will be ulnar nerve palsy. Now, coming to the anatomy of any nerve, you should understand the covering of any nerve to understand the physiology and the treatment of nerve injuries. The outermost covering of any peripheral nerve is called as epineurium. Epi means it is outside, neurium it is covering the nerve. So the outermost layer which covers the nerve is called epineurium. Within the epineurium we have bundles, and these bundles are called fascicles, and these nerve fascicles are covered by perineurium. Within the fascicles are further bundles of axons which are covered by endoneurium, and the innermost layer are the axons. So these black structures are called as axons, which is the basic functional unit of a nerve, and the axon is covered by endoneurium. The group of axons is called as fascicles, and the fascicles are covered by perineurium, and the fascicles together are in turn covered by epineurium, which is the outermost covering of the nerve. Now, coming to a diagrammatic representation of the same explanation, the violet colored structure is the axon. The axon is covered by endoneurium, and group of axons form the fascicle. The fascicle is covered by perineurium, and the group of fascicles together is covered by epineurium, in which the blood vessels supplying the nerve courses through. Now these are the three layers of the nerve. Now next, coming to the physiology, there are three types of nerve injury based upon the injury to the covering layers. The first type of nerve injury is a physiological conduction block in the axon. Like we are seeing in the picture, that the black axon is compressed from outside, but there is a thin line of axon which is continuous. So there is only a physiological conduction block, but the other covering layers, that is epineurium, perineurium and endoneurium, are intact, and there is no anatomical division of these layers. So this condition of nerve injury, where there is only a physiological conduction block without anatomical division, it is called as neuropraxia. Neuropraxia, since it is only a physiological block, once the block is reversed, the neurological recovery happens, and this type of nerve injury recovers. So spontaneous recovery is possible. An example for this neuropraxia is a Saturday night palsy, which involves the radial nerve because of compression in the region of spiral groove. Now the next type of nerve injury, instead of a physiological conduction block, there is anatomical discontinuity of the axons. So this axonal discontinuity, and in some cases there will also be discontinuity of the endoneurium and perineurium. However, the outer covering layer, that is the epineurium, is intact. So this type of nerve injury where axonal discontinuity is present but epineurium is intact is called as axonotmesis. Still, axonotmesis, the recovery is possible because the epineurium is intact and regenerative tissue can bridge the defects inside. But since there is an anatomical discontinuity of the axons, the process of Wallerian degeneration happens in axonotmesis, whereas in the previous type where there is only a physiological conduction block, like in neuropraxia, this component of Valerian degeneration does not happen. Now, coming to the third type of injury, the epineurium itself is completely severed, and once the epineurium is cut, it automatically injures the inner perineurium and endoneurium. So, this complete transection of epineurium, perineurium, and endoneurium, like what we see in a cut injury of a nerve by a sharp instrument, this is called as neurotomesis. And again, since there is an discontinuity of the nerve, Valerian degeneration happens here. But here, recovery is not possible spontaneously because there is a complete anatomical separation and we need to suture the cut ends for the recovery to happen. So, Valerian degeneration is present only when there is anatomical discontinuity, like seen in neurotomesis and axonotomesis, whereas it is absent in neuropraxia. Similarly, a spontaneous recovery is possible in axonotomesis and neuropraxia, whereas in neurotomesis, it is a completely sectioned nerve and you have to suture the nerve surgically. So these are the three types of nerve injuries. So anatomy, three layers: epineurium, perineurium, endoneurium, and physiologically three nerve injuries: neuropraxia, axonotomesis, and neurotomesis. Now coming to the ulnar nerve proper. First of all, we'll discuss about the course of the ulnar nerve and the causes of ulnar nerve palsy. Ulnar nerve originates from the C8 T1 roots in the spinal cord. It courses through the medial cord of the brachial plexus. In the arm, it is again on the medial side of the arm, medial to the brachial artery. Once it reaches the elbow, it courses behind or posterior to the medial epicondyle, where we can palpate the ulnar nerve subcutaneously, and any percussion over that side behind the medial epicondyle will cause a tingling sensation in our medial two fingers. That is why it is called as a funny nerve. In the forearm, again, it passes along the medial side of the forearm, and finally it enters the hand superficial to the transverse carpal ligament through the Guyon's canal. As we have all discussed previously, median nerve passes underneath the transverse carpal ligament, causing carpal tunnel syndrome, whereas ulnar nerve passes superficial to the transverse carpal ligament. Now, coming to the causes in the region of the elbow are any trauma, that is, a fracture or a dislocation around the elbow, can injure the ulnar nerve behind the medial epicondyle. Cubital tunnel syndrome is the compressive injury to the ulnar nerve behind the medial epicondyle. And the third condition is tardy ulnar nerve palsy. Tardy means delayed. When there is cubitus valgus, as and when the forearm goes into valgus, it stretches the ulnar nerve which courses behind the medial epicondyle, causing a gradual onset ulnar nerve palsy because of stretch. So these are the three main causes at the region of elbow. In the region of the wrist, again, any fractures or dislocations around the wrist, and aneurysm of the ulnar artery which runs along with the ulnar nerve can also cause compression of the ulnar nerve. So any lesion which is above the forearm, that is in the region of the elbow, it is called as high level lesion, and any lesion below that, it is called low level lesion. So what are the muscles supplied by ulnar nerve? In the forearm, it supplies the flexor carpi ulnaris, whose main action is flexion of the wrist joint. And the next muscle is flexor digitorum, profundus, which flexes the ring and the little fingers. So in low level lesion, flexor carpi ulnaris and flexor digitorum profundus escapes because the branches are already given in the region of the elbow joint. Once it supplies these two muscles in the forearm, it enters into the hand. In the hand, the main muscles which are supplied include, first is palmar interossei. Interossei because it is present between the metacarpals. In the hand, the middle finger is taken as the midline, and the movement of other finger towards the middle finger is called as adduction, and palmar interossei causes adduction. Remember the mnemonic PAD, P for palmar, AD for adduction. So palmar interossei causes adduction, that is movement of other fingers towards the middle finger, and this is tested by card test, which I will discuss later. The next muscle is dorsal interosseous. Here again, taking the middle finger as the midline, movement of the fingers away from this midline is called as abduction, and this abduction is caused by dorsal interossei. So the mnemonic is DAB, D for dorsal interossei and AB for abduction. So palmar interossei causes adduction of fingers and dorsal interossei causes abduction of fingers. Now next is lumbricals. Lumbricals are the muscles which originate from the flexor digitorum profundus tendon, and ulnar nerve supplies the medial two lumbricals, that is the lumbricals to the little and the ring finger. So what is the action of lumbricals? If you see the origin, it originates from the flexor digitorum profundus and it courses anterior to the metacarpophalangeal joint as seen in the second picture, and it inserts into the dorsal aspect of the extensor expansion. So since the muscle courses anterior to the metacarpophalangeal joint, when the lumbricals contract, it causes flexion of the metacarpophalangeal joint, and since it is inserted on the dorsal aspect of the finger, it further extends the interphalangeal joints of the fingers. Now remember this picture, when the hand is kept in the structure of L, remember the mnemonic L for lumbrical. It flexes the metacarpophalangeal joint and extends the interphalangeal joint. So this is the action of lumbricals. The next muscle is adductor pollicis. This is again an entrance exam question. All the muscles of the thenar eminence of the thumb is supplied by median nerve except adductor pollicis, which is supplied by ulnar nerve. So this adductor pollicis causes adduction of the thumb, which is necessary for this key pinch, holding a key and opening a lock of a door. So for that key pinch, adductor pollicis is needed. So these are the motor supply. Forearm, two muscles, flexor carpi ulnaris and flexor digitorum profundus. In the hand, it supplies palmar interossei, which causes adduction, dorsal interossei, which causes abduction, flexor digitorum profundus for the little and the ring finger causing flexion of the fingers, adductor pollicis causing adduction of the thumb, and lumbricals which flexes the metacarpophalangeal joint and extends the interphalangeal joint. Next is the sensory supply. It is an easier one. It supplies the medial 1.5 fingers and the medial border of the hand as indicated in the picture. So now what are the effects of ulnar nerve palsy? Again, to understand the effects, you should first make a tabular column listing out the various muscles supplied by the ulnar nerve. So the muscles include flexor digitorum profundus of the little and ring finger, adductor pollicis of the thumb, interossei, lumbricals, and hypothenar muscles, and finally sensory supply. Now, in a low lesion, that is lesion below the forearm, we know that all the muscles which are supplied by ulnar nerve in the hand will be absent, whereas the flexor digitorum profundus of the little and ring finger will be present because the branch for this is provided in the region of elbow itself. In a case of high lesion like injury around the elbow, all the muscles of the hand including the flexor digitorum profundus is absent. So the only difference between a low lesion and a high lesion is that in low lesion flexor digitorum profundus of the little and ring finger is working. So what is the significance? I'll explain in the next tabular column. So now these are the muscles which are paralyzed. Now we'll see the effects because of this muscle paralysis. Now first coming to adductor pollicis, as we told, adductor pollicis adducts the thumb and it is needed for key pinch. Now this is the normal key pinch. When a card or a paper is asked to held with the thumb and the index finger, the patient will be able to hold it normally just by adducting the thumb against the index finger. So this is normal response. Whereas when there is adductor pollicis weakness, the patient will not be able to adduct the thumb. However, he will not allow the paper to be pulled by holding it by flexing the interphalangeal joint of the thumb by the flexor pollicis longus supplied by median nerve, and this is called as Fromen's positive. Now this is the classical example of Fromen's positive. Here the patient is holding the paper by the action of median nerve that supplies the flexor pollicis longus and not by the action of ulnar nerve because adduction of the thumb is lost. This is called Fromen's positive, and here the key pinch will be weak. So what happens when the interossei is affected? As we know, interossei produce abduction and adduction of the fingers, and this will be weak. Adduction of the fingers is specifically tested by card test, which is similar to Fromen's test, where you insert a card between two fingers in the web space and try pulling it, and the patient will not allow you to pull by adducting the fingers and holding the card. If the palmar interossei are weak, adduction is not possible and we'll be able to pull out the card easily. So that is called card test. And in ulnar nerve palsy, hypothenar wasting will be present and the sensory loss will be numbness of the medial 1.5 fingers and the medial border of the hand. Now coming to the next classical picture of ulnar nerve palsy, that is claw hand. You remember the muscle involved in claw hand is lumbrical. Remember the mnemonic claw contains L. So in claw hand, lumbricals are paralyzed. So as we have seen earlier, keep your hand in L shape and the action of lumbricals is it flexes the metacarpophalangeal joint and extends the interphalangeal joint as shown by the red arrow. So when the lumbricals are paralyzed, the action should be reversed. That is, metacarpophalangeal joint should be extended and the interphalangeal joints should be flexed. And the clinical picture resembles like this. So this hyper extension of the metacarpophalangeal joint and flexion of the interphalangeal joint is called as claw hand, and when it involves only the medial two fingers because of ulnar nerve palsy, it is called ulnar claw hand. So remember, claw hand is metacarpophalangeal joint hyperextension and interphalangeal joint flexion. It is called claw hand because it resembles the claw of birds. So now the last. The difference between low lesion and high lesion is flexor digitorum profundus action is present in a low lesion, whereas it is absent in high lesion. What is the significance? Again, the entrance exam question is ulnar paradox. So what is this ulnar paradox? As you see, this picture is classical claw hand, that is metacarpophalangeal joint hyperextension and flexion of interphalangeal joint, and this happens in low lesion, that is lumbricals action are lost but the flexor digitorum profundus is acting, and hence flexion of the fingers are well marked, whereas in a high lesion the flexor digitorum profundus will also not work, and that is the reason why claw hand will be less deforming. So higher the lesion, lower the deformity, and this is called as ulnar paradox. So what are the functional losses seen in ulnar nerve palsy? Because of loss of the action of lumbricals, the patient will not have metacarpophalangeal joint flexion and will not be able to hold with a proper grip, and there is a loss of grip strength. Second is loss of pinch grip because there is loss of thumb adduction because of weakness of adductor pollicis. How will you manage? First step is you have to classify the type of injury, whether it is neuropraxia, axonotmesis or neurotmesis. Next, identify the cause of injury, and third, treat the cause of injury. So the general facts are, when there is a nerve injury, the nerve regenerates at an extent of 1 millimeter per day, and hence it is a slow recovery. If the target organs are not re-innervated within 2 years, then the nerve is not going to recover. In neuropraxia and axonotmesis, since spontaneous recovery is possible, observation is the main treatment, and in the meantime you ask the patient to do physiotherapy to keep the joints supple and to prevent hand stiffness, and the nerve recovery should be monitored regularly. If there is no response even after 2 to 3 months, then you have to identify the cause and treat it. In some time surgery might be needed. When there is a complete section of the nerve, as seen in neurotmesis, you have to explore and repair the nerve ends. In delayed cases, as I have told you previously, if the target organs are not regenerated within 2 years, then the muscle is not going to work even after repairing the nerve. So in these cases, instead of repairing the nerve, you have to do tendon transfers, that is, you have to transfer some other working muscle into the ulnar nerve innervated muscles to perform its action. So you have to do tendon transfers mainly to restore metacarpophalangeal joint flexion, to restore the grip, and thumb adduction to restore the key pinch. So to summarize, whenever there is an ulnar nerve palsy, look for the clinical features of claw hand, which involves the medial 2 fingers and the sensory loss in the medial 1.5 fingers. Examine for the functional loss of grip strength and key pinch grip. Then classify the type of injury. If it is neuropraxia and axonotmesis, it is managed conservatively with observation, physiotherapy, and treating the cause. Whereas if it is a neurotmesis or a complete section of the nerve, and the neurotmesis is identified early, the management is surgical repair or suturing of the nerve, And if the neurotomesis is identified only very late, then there is no use in repairing the nerve. And in these cases, you have to do tendon transfers aiming to restore metacarpophalangeal joint flexion to restore grip strength and adduction of the thumb to restore pinch grip. Thank you. Don't forget to like, subscribe and share this video to your friends. Thank you.